Good evening, everyone. I am Dr. Sharad Deshmuk from Medeli Hospital, Nasik. I am director of Medeli Hospital, which is a specialized center for gastroenterology and hepatology. So, coming to today's talk, we are going to discuss role of semi-elemental diet in pancreatitis. As we all know that during pancreatitis, the patient the enzymes which are released from pancreas are hampered and pancreas is not functioning proper, so the digestion process is disturbed, and if we give them diet, the pancreas has to work more and there is more release of pancreatic enzyme inside the pancreas, and there is more inflammation and worsening of pancreatitis. So next slide. So now, what is pancreatitis? Pancreatitis is basically inflammation of pancreas causing pain and digestive dysfunction. It is acute and it has two types basically, acute and chronic forms with different nutritional challenges. Malnutrition is common due to pain, malabsorption and reduced intake. Next slide. So what is semi-elemental diet? Basically, it is a formula containing peptides, medium chain triglyceride fat, MCT fats and simple carbohydrate. They are partially hydrolyzed proteins for easier digestion and low pancreatic stimulation compared to polymeric diet. So they are basically partially digested compounds. Next. So easy to digest. So role in acute pancreatitis, basically it improves nutritional status and weight maintenance. It is useful in patients with persistent malabsorption, adjunct to pancreatic enzyme replacement therapy. In chronic pancreatitis with exocrine insufficiency, means if the patient is having steatorrhea, that is fat malabsorption, in that patient's individual experiencing malabsorption and there is a weight loss, refractory steatorrhea, they will improve based by peptide based low fat regimen that bypass the deficient pancreatic enzyme. So in both the cases, means in acute pancreatitis and chronic pancreatitis, this has a rule. Next. Next. So in chronic pancreatitis, it supports early enteral nutrition when oral intake is limited, helps maintain gut integrity, reduce infection, and better tolerance than standard diets in severe cases. In acute severe pancreatitis requiring early nutrition patients presenting with organ failure, systemic inflammatory response syndrome, and they benefit from initiating semi-elemental feeds within 24 to 48 hours of curved catabolism, because what is initially it was thought that delaying enteral nutrition in acute pancreatitis patient is beneficial, but later on it has been found that early enteral nutrition, as soon as even by putting a nasojejunal feed, we can start early enteral nutrition. By that the SIRS, systemic inflammatory response, will reduce and the gut integrity will improve, so translocation of bacteria will reduce and there is overall improvement, and the patient will maintain its nutrition and the risk of infection will reduce. Next. So in World Journal of Gastroenterology, Pharmacology and Therapeutics, the nutritional and health benefit of semi-elemental diet, it is a comprehensive summary of literature. The outcome shows that there is a improved mortality and economic advantage as has been reported. In conclusion, the patients population that have difficulty digesting and absorbing standard diets, or those who are unable to attain adequate nutrition may be able to achieve improved health outcome and nutritional goals through the use of semi-elemental diet. Next. As far as the ESPN guidelines on nutrition in acute pancreatitis, the nutritional management of patients with acute pancreatitis is now guided by four main principles. The altered metabolism should be corrected by an adequate nutrient supply. To avoid iatrogenic complication related to overfeeding, to reduce pancreatic stimulation to subclinical nutrition to subclinical level. Whether this is important factor remains to be demonstrated, and to attenuate the overall systemic inflammatory response. In conclusion, nutritional support in severe pancreatitis is essential, and the route of nutrient delivery, whether it is parenteral or enteral, should be determined by patient tolerance. Enteral should be attempted in all patients. If the patient tolerates orally, it's fine. If he doesn't tolerate and the pain worsens after oral intake, there should be nasojejunal feeding should be started by placing a NJ tube. The clinician should monitor intake carefully to ensure adequate nutritional support. Many patients will require a combination of enteral and parenteral nutrition. Next. So there are a few case studies of the ICU-Pro peptide combination which is available. In first case study, a patient with acute gastroenteritis with dehydration, which is an elderly female patient. Her age was 79 years, underweight, BMI of only 17, no specified past history, DNR consent obtained at the time of admission, and the chief complaint were loose stools, generalized weakness, dehydration, reduced oral intake, and on examination she was dehydrated, mental status, she is conscious, her blood pressure was 118/70 and no documents, pulse was not documented. So as we know that her BMI was less, so initial diagnosis was acute severe gastroenteritis with dehydration and severe undernutrition. So management started was IV fluids, electrolyte corrections, monitoring of sodium level, nutritional and dietary management. Day 1 to lactose-free, gluten-free diet was initiated, RT was inserted, and ready to feed via formula through the hospital started at 80 ml every 2 hourly. Protein supplementation, ICU Pro supplementation was started, administered 3-4 times daily. Progressive feeding, gradually transition from liquid to semi-solid, soft diet, and oral feeds are tolerated well. Next. So, as far as the hospital course was considered, day 1 and 2 active correction of dehydration and electrolyte imbalance was done, and improvement in sodium and clinical symptoms. Oral intake improved, diarrhea subsided, and patient clinically improved on day 7. So outcome and discharge on stabilized electrolyte, corrected hydration, oral feeding established, patient discharge in stable condition. So clinical learning point in this case is that even if elderly female with gastroenteritis, high risk of dehydration and electrolyte imbalance was there, early nutritional intervention is crucial in underweight and frail patient, lactose-free, easily digestible diet, faster recovery, and protein supplementation like ICU Pro peptide semi-elemental form support strength, recovery, and prevent further muscle loss. Next. So this is again study with isoproalbumin and isopropeptide combination, which is effective nutritional management of hypoalbuminemia. Here the case is 60-year male with BMI of 21.9 and presented with pedal edema, shortness of breath, anorexia, generalized weakness, reduced morbidity. Relevant medical history: patient had hypertension, he has alcohol fatty liver disease grade 3, which is significant, portal hypertension, and difficulty in walking, chronic alcohol intake, abstinence for 6 months, poor oral intake, and with 6 kg weight loss over 3 months. His baseline lab parameters showed low hemoglobin, low albumin, CRP was high, which is the indicator of inflammatory activity, and SGOT, SGPT were 3 times elevated than the normal. So there was hypoalbuminemia with active inflammation and hepatic dysfunction. So IV albumin was not administered due to lack of patient consent. 1 unit of whole blood was transfused. And the oral nutritional support is advised at discharge: isoproalbumin 2 scoops twice daily, isopropeptide 2 scoops once daily. So it's a protein supplement with semi-elemental formulation. Next. So on follow-up result after 7 days, pedal edema resolved, appetite improved, body weight increased by 2 kilogram, overall strength and well-being improved, outcome and clinical impact. Within 1 week of targeted oral nutrition supplementation, and patient demonstrated significant rise in serum albumin level, marked reduction in inflammatory marker, resolution of edema, improved appetite, body weight and functional status, and follow-up laboratory value was there is hemoglobin improved to 10, albumin improved to 3.1, CRP reduced, and blood pressure was stabilized. So clinical message: targeted oral nutrition can effectively improve hypoalbuminemia and clinical outcome in chronic liver disease patients, even when IV albumin therapy is not feasible. Next. So thank you thank you for listening. And so the concluding statement is that patients with pancreatitis or malabsorption, in these cases, semi-elemental formulation plays a vital role. Even in cases of inflammatory bowel disease, liver cirrhosis, they had significant role. Thank you.
Thank you so much, sir. On behalf of entire Pollen team, if from the forum anyone has any query or questions, so please feel free to ask. So one question is came in a text to me that what should be the ideal calorie and protein we should go for the pancreatitis patient? If the patient is going through the pancreatitis, so what should be the ideal protein per body weight and the calories?
See, in acute pancreatitis patient, basically it is started from lower to higher, because it is just initially we give patient water orally or through NJ tube, and after that we start semi-elemental clear liquid or semi-elemental diet if the patient tolerates from the lower dose, and if the patient tolerates, we increase the feed as per his body weight. Means the requirement of calories is 30 to 35 kilocalories per kg per day, and proteins 1 to 1.5, and fat we generally keep low in acute pancreatitis scenario.
Okay, sir. Thank you so much.
And later on, based on the patient's tolerability, and we add on the digestive enzymes like pancreatic supplement for better digestion.
Okay, sir. I think you have given a very clear-cut idea for the use of semi-elemental dye in pancreatitis. So no questions being raised from the forum. So from behalf of entire Pollen family, I'd like to say thanks for your valuable time and putting the insights on this topic. Thank you so much, sir.
Thank you. Thank you.
Thank you so much, sir.
Thank you. Can I check out, sign out?
Sir, please. Thank you. I'll call.